right, thank you everyone. We're going to go ahead and get started. Thank you for coming to Workshop 17. This is a workshop on health equity, care delivery, and access to care, and there are many great workshops and sessions that are going on right now, so thank you for choosing to come to this one. Pridgy and I are privileged today to be able to serve as the workshop moderators. Pridgy is a nurse practitioner, a program coordinator, and a QI lead at UT Southwestern in Children's Health Cystic Fibrosis Center in Dallas, Texas. And I'm Ryan Perkins. I'm an adult and pediatric pulmonologist at Harvard Medical School, Boston Children's Hospital, and Brigham and Women's Hospital. Pridgy and I have no disclosures related to our presentation today. And so yesterday afternoon, we had a great session about value and health equity, and that it was a nice talk that really sort of set the stage for our session today. And so our session today, CF care delivery, access to care, and health equity all have significant implications for health outcomes for those within the CF community. Efforts to identify and reduce disparities, investigation into improving patient-specific care, and continued optimization of telehealth and exploration of remote monitoring applications have all shaped the landscape of investigative, policy, and advocacy efforts for care related to CF. This workshop will identify and discuss these current efforts and their impact on the CF community over the last year. And so our objectives for this session today are to identify different health disparities and social determinants of health and its implications on patients with cystic fibrosis in the US and abroad, to discuss various care delivery models that are tailored to individual patient needs, and to discuss health insurance and its implications on access to care and medications. And I would like to briefly highlight the CF Foundation and their commitment to equity, racial justice, diversity, and inclusion as the core principles to advance its mission to cure CF and provide all people with CF the opportunity to lead long and fulfilling lives. CF affects people of every racial and ethnic group, and many individuals with CF come from communities of color that experience disparities influenced by systemic barriers that have long gone unaddressed. And you can see here some of the work that the CF Foundation is engaged with, and you'll hear some of those efforts during our talk today. And we're privileged today to have 5 speakers here that are going to speak about various components of some of the efforts that the CF Foundation is involved with health equity, access to care, and care delivery. And just as a quick housekeeping note, our speakers will have 10 to 15 minutes to speak. This will be followed by a 5 to 8 minute question and answer session. Hopefully by now, you know if you have questions that you would like to pose to our speakers. If you'll go into the Workshop 17 section on the NACFC app, and in the bottom right corner, there's a question and answer tab. If you'll enter your question there, we'll pose that to our speakers. Thank you again for coming, and Pridgy, I'll turn it over to you.
Okay, thanks Ryan. So let's get started. Our first speaker is Olivia Dieni. She's a senior specialist on the Health System Innovation and Navigation team within the CF Foundation's Policy and Advocacy Department. Olivia manages cost and access research, leads payer engagement efforts to improve access to high-quality care, and works closely with Compass case management team. She will speak on CF community experiences with self-funded employer insurance. Please welcome Olivia.
All right, good morning, everyone, and thank you for being here today. I'm here to kick it off with everyone's favorite Friday morning topic, which is health insurance. But before I get started, I really want to thank our facilitators here for inviting me to speak today. It's truly an honor. I have no disclosures related to this presentation. All right, so I will be talking today about self-funded employer insurance. And before I get started, I want to take a step back and really define what is a self-funded or self-insured plan. So self-funded plans are employer plans. And essentially what happens when an employer decides to be self-funded is they are taking on the responsibility of paying for their employees and beneficiaries' medical claims themselves. So they are taking on that financial risk, and at times it can save them money, but sometimes it can be costly as well. Self-funded plans are very common in the United States, with almost 2/3 of employee-covered lives being self-funded. So They're very common, and I will say multiple times through this, not all of them are bad, even though I will be talking about access issues. Many have really wonderful beneficiary plans, although I do want to highlight some of the access issues related. So in contrast, fully funded plans are what you think about today when you think about employer insurance. This is when a person is paying, an employer is paying a premium to a Cigna, an Aetna, a large plan, and then they are not paying for those claims themselves. An important distinction between self-funded and fully funded plans is self-funded plans are not subject to state regulations. And I will get into why that matters in just a moment. So why am I talking about insurance and self-funded plans at this health equity session? Well, because as many of you know, and I'm really preaching to the choir here, we can have a whole slew of wonderful CF treatments available, but if people can't access them, then they can't benefit from them. So it's important to highlight the access issues related to these plans. And self-funded plans, as I've said, are very, very common in the United States. And because they are not subject to the same regulations, they have a lot of flexibility in terms of what they do and do not cover. So it's important to recognize the range. Some of them have wonderful benefit structure, and some of them are very limited in terms of what they cover, and that can create access issues for the CF community. So in terms of our actual analysis, we looked at Cystic Fibrosis Foundation's COMPASS case management data from 2020 and 2021. And we were specifically looking at COMPASS cases where a person called with a drug coverage challenge related to their self-funded plan. So we did not include cases where we were not sure or the COMPASS case manager could not verify that the plan was self-funded, and we also did not include cases where a person was calling, they did have self-funded insurance, but they were calling about something completely unrelated and it wasn't due to the plan itself. We then deduplicated these cases and did many sub-analyses that I will go into now. So about 11% of all the cases, all the drug coverage cases that COMPASS received in this time frame were due to these self-funded plan issues. And this was just under 50 of the cases they received. Again, as I mentioned, we did not include cases where we weren't sure if they were self-funded, so likely this number is probably quite a bit higher, but again, it can be complicated to identify self-funded plans, so we did not include those cases. We also saw cases all across the country and with employers that ranged very big, very significantly in size. Some of them only had a handful of employees. Some of these had over 500,000 people covered under their plan. So there weren't really any trends we could see in terms of those employer demographics. There were two different types of access issues that we did see from these COMPASS cases. And as you can see here, the most common one was those formulary exclusion cases, which was over 90% of the calls we received. And we're defining formulary exclusion as when a person would call COMPASS and one or more of their CF drugs was not included in the formulary and therefore not covered by the plan. The other issue that we saw, which was much less common but still important to highlight, is copay accumulators. And copay accumulators are not specific to self-funded plans. All different plans can have them. And these are programs where third-party copay assistance, such as manufacturer assistance, does not count towards a person's deductible or out-of-pocket max. This can increase the cost burden on people with CF and is very important to highlight. And this is where that difference in regulation comes into play with self-funded plans because they are not governed by state laws. And so there are 14 states today and Puerto Rico that have copay accumulator bans, but it's at the state level. And so self-funded plans can still have accumulators in places where there is a ban enacted. For the purposes of today's presentation, I'm really focusing on those formulary exclusion cases because that was the vast majority of what we saw. All right, so this chart is showing us the drugs that were actually people were calling about and that were excluded from the formulary in these cases. So as you can see, the vast majority were elexacaftor, tezacaftor, ivacaftor, or trikafta, with 60% of the people calling not being able to access it on their formulary. The second most common were the other modulators, which we grouped together for the purpose of this presentation. But one of the things that is really important to highlight here is that it wasn't just the modulators. There were other therapies people were having difficulty accessing. And the bar on the far right-hand side, you can see, is those who had difficulty with multiple treatments. So almost 1 in 4 people had difficulty accessing more than one aspect of their care, with some of these people calling and saying that all CF specialty medications were excluded from the formulary. So similarly to how there was a varied terms of formulary exclusion and what the drug was, there was a really varied response in terms of how these were actually resolved, and in some cases they were not. So luckily, we can say over half of these cases did end up with the person having access to their treatment. However, as you can see, the method of getting that resolution varied quite a bit. So only about 1 in 5 folks had their actual existing self-funded employer insurance cover the medication. Other folks had to enroll in manufacturer assistance or patient assistance programs, free drug programs. Many changed insurance, and some got their secondary to cover or used other methods. It's important to highlight 16% of people did not get access at the end of these cases. These folks were planning on looking at different insurance options, but at that point had not yet changed insurance, so they were going without their treatment. And still more, you can see that 31% of people, we don't know what happened. These are cases where people are calling Compass, and many folks are lost to follow-up. And so we're not sure what happened in those cases. We can hypothesize, but really we don't know at all what happened with those folks. So what are the impacts? Unfortunately, they can be significant when people are facing these issues. So 56% of people experienced a gap in care with the issue that they were calling about. I'm again preaching to the choir here. We know even a short gap in care can be significant and have serious health declines. And so I don't know the ranges of the gaps in care. A lot of this was reported by the person, so I couldn't answer, how long they were going without. But we do know that that gap can be significant, even if it's only for a day. And these gaps in care were not always resolved with their insurance. As I showed on the last slides, many people had to change insurance with almost 30% of all of the cases, those that were resolved and those that were not resolved, ending with the person needing to change their insurance to obtain access to their medications. Also, while it's not always documented in Compass cases, I think it's important to highlight the time and the administrative burden of these cases. This can have a significant time burden, mental health burden, quality of life burden on people navigating insurance. I think we're all very familiar with the complexity of insurance and the many people that need to be involved. So it's important to recognize that impact on patients, families, and care teams. All right, to summarize, again, I will say it, not all plans are evil, not all these self-funded plans are bad, even though I spent the last few minutes talking about how they are. But it's important to recognize they can pose very unique access barriers to people with CF due to their freedom of that formulary management in terms of what they do and do not cover. Underinsurance is a problem where people are insured, but they do not have access to the treatments that they need. And this underinsurance can result in people having gaps in care and can result in them needing to change their insurance and look at a different plan. However, some of these can be resolved with the employer. There are cases that we have heard where employers are not aware of the impacts of this, and through education they will cover these drugs, and we have seen that happen. And so it's important to recognize that these cases are complicated and they have many different paths, but they can result in coverage for people with CF. Additionally, Compass and care teams, of course, can support people who have these self-funded insurance challenges. It's important to recognize the difference in the types of challenges that exist and how the resolution may require some creativity and some different approaches, but it is possible to do, and really recognizing that and supporting patients through it is essential. And finally, this was a convenient sample of Compass cases. We know that these challenges exist and more research is certainly needed to understand them, their impacts, and of course the health implications of the gaps in care that people may be experiencing. All right, so I would like to thank my co-authors of this poster. I don't think I mentioned, but it is a poster and it's 362. So my co-authors are Kelsey Dahlquist and Hajin Moon, and of course I would like to thank the CF Foundation's Compass case managers. I am up here talking about this data, but they are the ones who are actually talking with people every single day and helping support so that everyone has access to their high quality treatments. Thank you.
Thank you, Olivia. So now it's time for questions from the audience. I don't see any on the iPad. If you want to stand up and ask, that's fine too.
This has come up recently a couple of times with my adult patients. Just to give a few examples. One sent me a frantic email and said, I just received notice that my insurance is no longer covering Trifactor or Creon. What am I supposed to do? This is their dream job that they went to school for, and so they don't want to leave, and how do you afford insurance? So I'm wondering, how can we advocate for our patients with their employer-paid coverage, because I feel like they're in a really difficult spot because it's their employer who they're trying to go to and say, I want you to pay for these really expensive drugs. They're getting chips.
Great question, and I think one that I am not a case manager, so I will say that, and I'm not an expert in all of it, but I think it really varies person to person. Some of these employers, as I mentioned, are unaware of these challenges, and through education and the person explaining their situation, of course, the person has to be comfortable explaining their situation to their employer and comfortable disclosing that they have cystic fibrosis, which not everyone is. Some of those employers will issue overrides and cover the drug. Other people do end up looking at marketplace options and seeing if they can negotiate something with their employer so that they can have a discounted premium or have it more affordable in terms of marketplace. Those are the two most common we have seen. Unfortunately, these cases, we don't have an easy answer in terms of a one-stop solution for how to access the medications.
Go ahead.
Just to follow up on that, does Compass help provide that information, or what is Compass' role?
Yeah, great question. So there's a couple different things Compass can help with. First off, I want to say identifying self-funded plans can be really difficult, and I think a couple tips in terms of how to actually recognize this is on the back of a person's insurance card. It often says this plan is administered by, or the insurance you see on this card is not actually the one administering the benefits. That indicates the plan is self-funded, because a person's insurance card with self-funded often looks very similar to those who are fully funded. This is because employers are usually working with a Cigna and Aetna to do the administrative side, even though they're paying the claims themselves. So first off, they can help identify and do their best to help identify when a plan is self-funded. Other things that Compass does is they will do the detailed benefit verifications and understanding whether there is sufficient coverage from the plan. If it's not sufficient, they can help folks look at all plans they are eligible for and do a side-by-side comparison in terms of what is available and other resources they might have. For example, with a copay accumulator, looking at other financial resources that might be available. Finally, they will help the patient or the caller, whomever it might be, frame questions and get the right information, maybe the right data, if there's that sometimes can help sway employers in terms of the benefit of these treatments. And help support them so they can advocate on their behalf. Compass does not write letters or do that individual advocacy.
Thank you. Olivia, here's a question for you. For self-funded plans, are there any regulations against formulary exclusions for medications that don't have an alternative, such as Trikafta and Pulmazine?
So unfortunately, right now, these plans can carve out these drugs. It is a loophole in some of the legislation that exists today, so they can exclude Trikafta from the formulary. Again, I'm not a lawyer, and I won't get into the details of the laws themselves, but unfortunately, that is how it is today. There is legislation on the table right now on the federal level, the Help Copays Act, that the CF Foundation actually has started a campaign for if you want to sign up. And I actually don't recall the number, so I see Scott in the audience. If you don't mind saying what people have to text to get involved in that. Sorry for putting you on the spot.
You can text copay to 96387. That'll be able to easily weigh into legislation.
So
936
copay to 96387. If you text that and go through, you can be a part of that advocacy campaign at the federal level.
And Olivia, we have another great question here. Do these type of plans affect things like access to birth control or fertility treatment?
We have not seen that. I'm honestly not sure. And so I would have to circle back with whomever asked that question. I can't 100% answer.
I can only answer because I worked for a housing agency many years ago, and they can exclude certain kinds of services.
Mhm.
In that case, for religious reasons, but they can. So when I worked there, there was no coverage for birth control, or there was very limited coverage for fertility treatment, that sort of thing. So my experience was that they can. That's what I know.
Thank you.
Thanks.
And then we have another great question too. Sometimes there can be very challenging access gaps for patients who are undocumented or international. Do you have any tips or things that you would suggest for this population of patients?
Call Compass.
Good
I'm
answer.
sorry, I'm not a case manager. I can't, I would be scared to tell you the details of how they navigate some of those cases.
Yes.
Does the data show whether
Great question. So for some of these plans, the formulary exclusion was partially due to a third party. We call them alternate funding programs that will exclude the formulary, or pardon me, exclude the treatments. At the end of the day, the employer is the one who is responsible for the decisions that are made. So when the third party is involved, the employer may not be aware of what is happening, and because not everyone who works in HR is an expert in every disease, which of course is reasonable. But at the end of the day, it is the employer who is the one who would have to issue the override. They often outsource that to these other third parties. There were quite a few of these cases. I would have to look at the data to see the specific number that were these alternate funding programs, but they are very common in CF where they will exclude a drug, with self-funded plans, I should say, they exclude a drug from the formulary and then try and have that person get on the patient assistance or the free drug program to avoid the employer having to pay that cost. So that is something we saw quite a bit. I think it was about half of those cases of formulary exclusion, but the specific number I'd have to double check. Thank you.
One last one, go ahead.
Can you talk a little bit about the systemic policy landscape?
Yeah, so it's complicated in the self-funded employer space because, again, they are not subject to the same regulations, and some of these, I think, important to highlight again at the state level before I even go to the federal level, what is happening, because people may think they have an accumulator ban, but if their plan is self-funded, then they can have an accumulator in that state. At the federal level, again, the Help Co-Pays Act is available, but what we're seeing right now, it's on the floor of the House, or pardon me, it's been introduced to the House, and so that's the best thing to have to resolve these issues. What we're seeing today is plans are essentially stating that specialty medications, it's a loophole in the Affordable Care Act where specialty medications are not determined to be an essential health benefit, even though prescription drugs are an essential health benefit, and that is how they are able to avoid this regulation of the Affordable Care Act and not cover these drugs because they're saying they're not an EHB. And so that Help Co-Pays Act would resolve this and close that loophole, so encourage you all to text copay to 96387.
Yes.
And thank you all for your questions. Olivia, thank you for a very engaging talk. If we didn't get to your question, Olivia will be around after the talk and we'll be happy to address any further questions. Our next speaker is Dr. Megan McGarry. She is an associate professor of pediatrics at the University of California at San Francisco. She investigates health disparities in cystic fibrosis, including in Hispanic children with CF, access to drug trials, and newborn screening. She will speak today on the detection of disease-causing CFTR variants and state newborn screening programs. So please welcome Dr. McGarry.
Welcome and good morning. It's so great to see a packed room, and I'm just thank you all for being here and being interested in this. So I'm here to speak to you about our research on detection of disease-causing CFTR variants in state newborn screening programs. There we go. So I have grant funding from the CF Foundation, from the NIH, and I've also been a consultant for Genentech on health disparities. So newborn screening has many, many benefits. It's one of the best things that the CF community has done. So we have improved survival, higher pulmonary function, less frequent Pseudomonas aeruginosa infections, fewer hospitalizations, and the improved nutrition and growth. So just to go over just the newborn screening protocols is that newborn screening has been across the United States, DC, and Puerto Rico since 2009. So all programs start with immunoreactive trypsinogen, IRT, trypsin precursor. It's elevated when pancreatic enzyme release is impaired, and it's not converted to active form, so it's not removed from the blood. So that's why it's elevated. And then all states do some form of CFTR variant panels. So the newborn blood spot analyzed for a list of CFTR variants, and this number varies greatly. So it goes from 1 variant to over 300, depending on what state your baby is born. Some states also do CFTR sequencing, and there's varying protocols that we'll talk about on how this may be. So positive newborn screens in most states need at least one variant identified. So that one variant is really important. There are some states that have fail-safes where if there's a very elevated IRT, it'll be positive no matter what. But that one variant is very important. So this is data that is under review right now, not by me. And you can see that I was just lucky to get access to it. That's a preview. The number of variants really vary in the panel by states. So you can see that the 2 states that only have one, which I think New Jersey just changed, so good job. Yay! But you can see that some states have a lot. And so where you're born, one state you may be positive, another state you may be negative and be missed. So sorry that this got messed up, we just changed it. So CFTR genetic variant frequency varies among races and ethnicity groups. And it's dependent on ancestry admixture, which means where did your ancestors migrate from, were enslaved and moved from, where is your background from? And we know that you can trace genetic variants based on that. So because of those groups, it's very different. And we know that minoritized racial and ethnic groups are more likely to have what we call rare or de novo variants, which may not be rare in that one group, but are rare overall. And that CFTR variant panels were really developed on non-Hispanic white populations. And so what we wanted to do is look and see how do these variant panels work in all races and ethnicities. So we did a cross-sectional analysis of all the CFTR variants in all genotype people in the patient registry in 2020. And what we did is, using these 7 genetic panels, we calculated the detection rate of detecting 1 variant or 2 variants by race and ethnicity. Then what we did is we took those the detection rates for each panel and we applied it to the latest census data. So we took each state's census data, their race and ethnicity breakdown, we applied the detection rate, and then was able to calculate or estimate about how well each variant panel would work in each state. And then lastly, we looked at the false negative rate and delayed diagnosis by race and ethnicity in the patient registry since newborn screen has been started. So these are all the variant panels that we looked at. The ones that are starred are the ones I'm going to present. So to look at the case detection rate. So this is the ACMG panel, which is a 23 variant panel that's commonly used, particularly in prenatal screening, but also many of your states also use it for your newborn screening. So it looks great, 93% detection rate, that looks awesome. But when you actually look at your Asian babies with CF, you're gonna miss almost half of your babies. The African American or Black babies, you're gonna miss about a quarter. And then you're gonna miss about 15 to 20% of your Hispanic, American Indian, or mixed race babies, while you're gonna detect almost all your non-Hispanic white. And then the Native Hawaiian, there was only 7 people in the registry who were Native Hawaiian, so I would not put too much faith in this data. I think we have a lot of people with CF who are Hawaiian who are not in the registry. So now looking at the Luminex 60 panel. So 60, much better. We're up to almost 95% detected. Still missing about a third of your Asian babies. 20% of your African American or Black babies missed. Now back up to like 10 to 15% of your American Indian, Hispanic, or mixed race babies with very good detection in non-Hispanic white. So you can see how, if you look at the detection rate overall, it's really masked by your overwhelming non-Hispanic white population that you really aren't able to tell that these are actually poor screening tools. So moving on to the Lumina 139 panel, once again, overall, not much difference in your detection rate going from 60 to 139 overall. But now we move up to only a quarter of your Asian babies being missed, which is still horrible, but much better. And only 15% of your African American or Black babies being missed. Now up to about 10% of your other groups, and then a little bit of improvement in non-Hispanic white patients. So then the biggest panel we did is we said, great, let's go to the CFTR2 database, all the variants that are known to be disease-causing. So not ones with the varying clinical consequences, but ones that if you have those variants, we definitely know those have caused cystic fibrosis. So those are 401 variants. So once again, you see overall, it doesn't really improve your overall detection rate. But what you see is that you have a little bit of improvement in your Asian babies with CF. You have a lot more improvement in your African American Black babies, and then a greater improvement in your American Indian, Hispanic, mixed race babies. And so really what you see is that we don't really understand and the variants that could cause CF in Asian babies, in African American babies. We don't have these very well described. And so that makes it very difficult to use a screening tool for this. So we took all those detection rates and then we applied them to the census data for each state. So this is how your state would do if you use the ACMG panel based on your latest census data. So what you can see is that states that are on the left with lower rates of detection are states that are more diverse. Hawaii, Puerto Rico, California, DC, Maryland, Texas, Georgia, New Jersey, Nevada. And then states that are more homogeneous population on the right, Montana, Vermont, West Virginia, and Maine, higher rates of detection. And so for example, so in California, if we were to apply this, we would have a 17.9% false negative rate, which means that of all those babies born, we'd be missing about 18%, where we would say, no, your newborn screen's normal, you don't have CF, and in reality, they would have cystic fibrosis. So next is the Luminex 60 panel. So you can see improvement overall, but still wide variety amongst the states and how these panels would work. Hawaii is horrible down on the left. And you can see that it would improve for California to like a 12.6% false negative rate. The Lumina 139, you can see there's improvements, but still those disparities exist. And then finally with the CF Terror database, you see that there is a vast improvement overall, where only Hawaii and DC are below 90%. All the other groups are in the 90s. So lastly, we're going to talk about false negative newborn screens and delayed diagnosis. So what we did is, this was a smaller population we looked at, so just the CF population born 2007 to 2020. And what we did is we compared race and ethnicity of the entire CF population born during that time to the false negatives and then to the delayed diagnosis. So you can see that Black and African American, Hispanic, and mixed race population was overrepresented in the false negative and delayed diagnosis. So for example, 3.6% of the children born during that time with CF were Black, but 6.5% had a false negative newborn screen, and then 6.5% also had a delayed diagnosis. Now, Hispanic babies made up 8.6% of this population, but were 15.5% of our false negative newborn screens and 23% of our delayed diagnosis. So now the delayed diagnosis is over 180 days old to be diagnosed. Mixed race babies were 2.4% of the overall population, 5% of the false negatives, and 5.7% of the delayed diagnosis. And these are just really unacceptable numbers. So in conclusion, we need a lot more research in these variants. So we need more to know more about these variants that are occurring in our babies so we can have better detection. And we need to really be thinking each state is, what variants do we need to be adding? What panels should we be using? These numbers are just unacceptable. And then what we really need to be looking at is looking at the DNA variant frequencies that are in the registry, and then looking at your own data to identify population subgroups in your state. So if you're just looking at your detection rates overall, you're gonna be masking these smaller groups that these tests are doing really poorly in. And then to consider using CFTR sequencing rather than panels to improve detection across all races and ethnicities. California, New York, and Wisconsin are all doing this in varying protocols that have really helped improve detection in these other groups. The other thing is to consider an ultra-high floating RT that would catch at least some of these babies, no matter what their genetic variants are. But really, we need nationwide quality improvement to reduce health disparities in all races and ethnicities. And if you were at the the presentations, the cases this morning, there was a very nice case that showed that there was a baby who's missed on newborn screening, and then once again didn't get diagnosed until I believe 5 years old. And part of that was because then the thought was that the baby did not have cystic fibrosis. So there's this false assumption amongst pediatricians, family doctors, that the newborn screening was normal, so we don't have to worry about that. Whereas you can see in some of these other groups, you definitely have to worry about it. So I'd like to thank my other co-investigators overall. And then, and I just wanted to say that, when we're thinking about health disparities and we're thinking about our populations we're caring for, we really need to encourage the CF Foundation that all future meetings need to be a place where state leaders know the importance of reproductive freedom, gender-affirming care, sanctity of the physician-patient relationships, and really that healthcare is a human right, and we need to be supporting that. Mm-hmm. So overall, I welcome all questions and answers. My slides did not get updated, so I had a nice QR code so you could look at the paper, but the paper is open access. It was published 2 weeks ago. So you can Google it and see all the data because we went through all the states, all the panels, and you can really see all the data. But if you ever needed me or wanted me to talk about and help your state, just let us know. I think there's going to be a lot of work over this next year. The CF Foundation is very committed to seeing equity in health disparities eliminated in newborn screening. So thank you.
All right, thank you, Megan. Just a reminder, if you have questions, please ask them in the app. But I'll go ahead and get started with the first one. It seems like there's great variability in testing that's done by state, and you've identified some things that we can do to help reduce some of these disparities. What can we do in our own individual states to help implement or advocate for some of these suggestions that you're making?
So I think one of the first things you can do is find out who in your state lab, your public health department, is actually doing CF newborn screening. Public health has really taken a hit over these last couple of years with COVID and people being burnt out, and then also the politicization of public health. So find out who these people are. They may be brand new, they may be burnt out, and then starting to talk to them about, okay, what are we doing? Have you looked at the data? Trying to engage them on this process. Once you find out what is going on, then you can start identifying the problem. So I know that this has really been good in our state where our public health officials were just really burnt out. Once we started saying, well, like, hey, can we start looking at this data? They got excited about cystic fibrosis again. And then I think if you have a fixed IRT, you can start talking to them about whether or not we need a floating IRT, which will help you miss cases. If you are one of those states that has very few variants, you can start talking to them about, well, hey, let's look at the missed cases. Are you collecting data on that? And then working with the CF Foundation about figuring it out. But I think the other really thing is that you need to vote this year and you need to vote in 2 years because funding for public health is very variable on who is in office, and that if funding starts getting cut for our public health departments, we are going to be going backwards in newborn screening. So.
Megan, a question for you. How did you come up with the 180 days as a definition of delayed diagnosis?
So I believe that it's something that has been used before. It is something that we sort of picked that would sort of show that it was definitely delayed. I think that you could use other variables. Susanna will jump in on here.
Yeah, so this is an a priori diagnosis that we made for the 10-year evaluation of newborn screening. Megan worked with the registry team and others on that team for this analysis. But historically, for newborn screening, the median age of diagnosis of a baby with CF was 6 months. And so, and then the need was like 5 years because of all the variation. But we chose it based on historical records, so later than average had you not been newborn screened, which is pretty, it's actually a pretty literal. It probably should be a lot less than that, but it was a priori chosen.
Perfect. Thank you.
Someone asked the question, in order to prevent false negatives, do you think states should adjust newborn screen reporting such that high IRTs in non-Caucasian patients automatically flag as abnormal and require sweat chloride testing?
So it's something that could be considered. I think IRT levels are a little bit difficult. We know overall that people who identify as Black or African American have higher IRT levels overall, and it's not clear why. So that's one thing that you would have a lot more Black and African American people without cystic fibrosis overall having to go through screening. But it is something to consider, and I think that is where those fail-safes come into play about what it is. But one of the nice things is that you can start looking at who was missed. Stacy Martiano went and looked through the Colorado data, looking at who was missed, looking at historical IRT levels overall for their population, and then they were able to go through and adjust their IRT level and the way that they did it so that they were able to improve screening. So there is a lot of looking at your own data. One of the other things, IRT is really labile, and so heat can affect it. So even like climate change is going to be affecting our IRT levels. So there is a lot of really a lot of attention that needs to be done looking at your data and adjusting. So.
Perfect. So Megan, there's a lot of folks in the hub. They want to know how do they access the QR code?
So if you just Google right now, like Megan McGarry newborn screening, if you Google it, it should pop up as the paper. I had a QR code up, so it would just bring you right to the paper. The paper is open access, so you'll be able to pull up the full data no matter what. It was published on Pediatric Pulmonology, so you can also go to their website and look at it as well. But it should be easily to find. Also, if you just can't find it, you can email either me or Susanna, and we can just email you a copy as well. So, and I can put it on Twitter if you want as well, if you're on Twitter.
Sure.
So.
Yes. All right.
I have put it on Twitter, but I'll play it again right now, so it's easy to find. But I think this is really, the last 10 years has been really a lot of CFTR modulators and talks about things, and this is really time now to double back down on our prevention of let's get these babies diagnosed early and get them into treatment. Because the other part of this is that once these babies are missed, we have so many stories of families where they're licking their babies, tell their babies are salty, and they're going to the doctor saying, my baby is can't gain weight, has respiratory infections, is salty, and doctors are laughing in their faces. And this is not just one family, this is across the board. So these families have such a hard time getting diagnosis because of these wrong assumptions about CF. And so this is where this early detection is even more important because these families, even though they are good advocates, they cannot get diagnosed. And so it is really important to get these babies picked up on newborn screening.
And not only that, if they're diagnosed late, then it's also the acceptance, right? So families have a harder time accepting this diagnosis and thus, delaying further care for them. So very important.
Yeah, and I think families also have a lot of trauma from that. And they also have a lot of mistrust. So if you're getting laughed at, you have to dismissed and then by multiple doctors, and then you're going into CF care, you are coming in at a very different place. And then you have a very sick baby who's going to need a lot of attention and a lot of catch up. And that's just where we're seeing there's some work that Susanna has out that shows that that they're not catching up, right? You're seeing long-term nutritional deficiencies. And so this is just such a huge importance. Liz, really thank you all for being here. Always available for questions. Contact me with anything, and we're glad to help. But, just keep doing good work with your patients, and just thank you.
Thank you. All right, let's keep this going. So the next speaker hails from my home state of Texas is Dr. Sanjay Devarajan. He is originally from Dallas and went to medical school hoping to be a primary care physician. After doing a peds residency at Georgetown, he fell in love with the medical ICU, returned home to Texas for a pulmonary critical care fellowship. He joined the Baylor faculty in 2019 and focuses on the care of people with CF and bronchiectasis. His talk is on the evaluation of outcomes in Black people with cystic fibrosis using the CF Foundation Patient Registry. Welcome, Dr. Devarajan.
All right. Great to be here. Love the packed crowd, and it's a great mix of people that are speaking today, and I'm so happy we get to share what we're doing in our work with you all. Bridget and Ryan, thanks so much for inviting me. This is a really big honor to be asked to speak here. So let me start off by saying I am a self-loathing Twitter user myself. But if you're interested in CF, non-CF bronchiectasis, that's my handle down there on the bottom left. So feel free to follow along with my self-loathing tweets. I'm going to be talking to you about outcomes in the Black population with CF. For simplicity's sake, in the registry, it's the population is referred to as Black, non-Hispanic. So I'm going to just simplify it. For the purposes of this talk, you're going to hear me refer to the Black population. And if there's any trainees in the crowd, this was not a passion project for me. It was a curiosity and interest. And sometimes if you pull on a string, it'll take you places. So always keep that in mind. I don't have any relevant disclosures. So let's talk about the minorities' experience with CF, because there's not really a tremendous amount of data. Probably the most robust data that we have is in the Hispanic population. And in general, hate to say it, Hispanics generally have done worse with CF. There was a nice study from California by Dr. Mimi Bu, published in Chest several years ago, which showed substantially higher mortality rate in this population, so a hazard ratio of death of 2.8, significant. And nationally, Dr. Jane and colleagues demonstrated in the Blue Journal, ATS, that Hispanics generally experience a shorter life expectancy or higher mortality. And as Dr. McGarry expanded on, this may be due to a variety of reasons, but one of the reasons is that CFTR mutation detection is delayed in minorities, and it's generally less frequent based on the panel as state decides to use or not. What data we have on the Black population is there's a paucity of it. There's not that much of it. But what we do know is that Black people with CF tend to have poor nutritional status and pulmonary function with respect to the white population with CF. So that's what we know. Now let's quickly talk about modulators. This is from Dr. McGarry and Dr. McCauley's paper in 2021, which looked at eligibility for CFTR modulator therapy across ethnic groups or racial groups. And what I want to point to you, if I can, I guess not here. So if you look at the top row, you'll see essentially more than 90% of the white population would qualify for one of the modulators as of 2021. And that number is less than 70% in the Black population, only slightly higher in the Hispanic population, and then only slightly higher after that in the mixed or other race population. So there is a big discrepancy there from an ethnic and racial standpoint. So what's the incidence of CF in Black people? Interestingly, there was a paper that came out almost 50 years ago, which actually pretty much nailed it, that a baby that's born today has a 0.005% chance of having CF. This is actually from a case series out of DC, which kind of nailed it. And if you look at the CFF data set, and this is interesting because I got this from the data report from 2020, and they seem to have combined the Hispanic and white population at 92%. I should probably tell them about that. But the next largest group is going to be the Black or African American population, which is standing at 3.5% as of the 2020 data report. So my project, what we wanted to look at was do a survival analysis of Black people with CF, CFTR-related metabolic syndrome, and CFTR-related disorder. These are all diagnoses that are included in the registry, and we thought it best to include all of this. And so this is based on the CFF patient registry data, and we wanted to stratify outcomes based on race and ethnicity. And the primary endpoint that we wanted to look at was actually a composite endpoint. We actually wanted to look at age at lung transplant, or the median age at lung transplant, or the median age at death, and put that into a combined primary endpoint. Why did we do that? Well, there's a pretty good basis for it in the CF literature, and if you think about that decision point when you decide to list somebody, if they don't get listed, there's a very high likelihood they're going to die. So we thought that would be a good place to sort of to see what the outcomes are. And we got a little bit more into the weeds on that, as I'll show you. The secondary endpoint was pretty easy. We just wanted to look at the rate of decline in FEV1, and that was our primary second endpoint. The hypothesis was, based on chronic diseases like coronary artery disease, for example, that Black people with CF would have worse outcomes. So what did we do? So we had this very large registry data set, actually going back to 1986, when the registry was first born. We had all this data. And we actually played with some different models, and what we found out was that when we were adjusting for certain things, we had a lot of missing data. So we kind of fine-tuned our approach and actually just looked at 2012 to 2019, inclusive of these years, so 8 years total. The diagnoses I already told you about. And we looked at people's age 6 to 54. The idea is that spirometry, which we're relying a lot on, is not reliable in kids under age 6. And at least the quantitative values are not reliable. And then we used an age cutoff of 54 because based on a paper by Jerry Nick that reporting to the registry of deaths in people aged 55 or greater drops off significantly. So we thought we would actually miss a lot of people if we included anybody older than that. So as you can see on the bottom, we excluded some people, which I'm happy to expand on offline, but we thought it was justifiable to exclude these people on the right. And we were looking at a data set of more than 30,000 patients. And this is all the various things we looked at from a baseline standpoint. And what I'll say is that we used a couple of different models, as I'll show you, but we wanted to kind of account for all of these things which could have an impact on our outcome of being transplanted or dying from CF. And we use what's called, we use baseline covariates, and we also use what are called time-varying covariates. We use 2 different models to see if there were any difference. The idea being that somebody who enters the study at 2012 when ivacaftor alone was available, in 2016 they may have been started on dual CFTR modulator therapy, and we wanted to be able to account for that change over time. One thing that we did use as baseline was just the number of hospitalizations, so we didn't kind of vary that over time, because if somebody was transplanted, let's say in 2018, and they had 8 hospitalizations, you wouldn't know temporally were those before transplant or were they after transplant. So we looked at a baseline entry in 2011 of the number of hospitalizations. And this is kind of how it shook out. I hope you guys can see that in the back. Again, what I want to sort of point out here is that there were a lot of differences. If you look at the p-values across these characteristics, this just tells you that there's at least one group in each of these categories that's different from the others. And what I want to point to are, if you look at the 508 2 copies, you see that almost 55% of the white population is going to be homozygous 508 in this time frame. In the black population, it's 23%, so substantially less, so that has a big impact on modulator use, right? And if you look at CFTR, Everon modulator, so to kind of go along with that, the bottom yellow line there, you can see that about double the white population was on modulators at some point during this 8-year period. And again, most of these comparisons were significant between the groups. So what I'm showing you here, this is called a Kaplan-Meier curve, and this is looking at that primary endpoint. And this is unadjusted, so we didn't actually adjust for all those characteristics that I showed you. And as you can see, there is a p-value that's very low, and it turns out when we looked closer at this, that primarily in the unadjusted look, there was primarily a difference in the white population and the Hispanic population. So this goes along with prior conclusions in CF where the Hispanic population does worse. Now what if, so these are the p-values using that Kaplan-Meier curve. If we were going to use the black population with CF as our reference point, and we compared it to the other racial and ethnic groups, these p-values are all greater than 0.05. So this unadjusted look would tell you there is really no difference in getting to that primary outcome in black people versus other races and ethnicities. And if we were to start adjusting using this model, with adjusting for all of those baseline characteristics that I mentioned before, again, you see that the overall P is fairly high, and none of these achieve statistical significance. So what does this mean? So what this means is that for these models that we use, there was no difference in the primary outcome of death or transplant. And so, we kind of scratched our chin and we were, wondering, are we asking the right question here? Because if you've ever taken care of somebody who is about to be transplanted, you know that there's a lot of factors. There's usually, multidisciplinary boards and review groups that will look at these cases. And so if you're going to use this composite endpoint, it may not give you the whole story about things like bias. So what did we do? So what if you were to break down this further? So if more than 3,000 people hit that endpoint of transplant or death, what if you were to break it down into categories? So it turns out 1,443 people in this group were transplanted, 1,905 died. And what if you broke this down by race and ethnicity? What if you looked at this if you stratify by race and ethnicity? So this is a model which is showing you what's the age at transplant with a competing risk of death using all of these adjusted things that we looked at. Okay, so what does this tell you? This is going to tell you, okay, of those people that were transplanted in that group, what was their racial and ethnic background like? And again, we use the black population as the reference. And if you look at the white, Hispanic, and other / multiracial populations, what you see is that you're starting to see some signal here. So what does this mean? So that means if you take the white population, for example, the white population is more likely to have, of the people in that group, they were more likely to be the ones that were transplanted. Likewise, the Hispanic population, and likewise the other and multiracial population. But what if you were to ask the reverse question? So if you were to ask, what is the median age at death in these populations based on their race and ethnicity? Now you got the overall P is in the significant range. And again, we're using the black population as the baseline. And what you start seeing is a big signal here in if you compare the white population to the black population. So this would seem to suggest, if you're using both of these competing risk models, that the white population is much more likely to be transplanted, less likely to be more likely to be transplanted, less likely to die than the black population. I'm sure there will be questions on this, so we'll take that at the end. And then our secondary endpoint, we use something called mixed effects linear regression, and basically plotted these folks' lung function by FEV1 over time. So you can see we've got nothing below age 6 and nothing above age 54. So how does this sort of shake out? Well, this shows you that everybody has some decline. That's what these p-values show you, that there is significant decline in all these groups. But what if, again, you were to use the black population as your reference point? And what you see is that, interestingly, the only thing that's significant is that if you look at the black population versus the Asian population, the Asians with CF tend to have slower, less lung function decline over time. And so what are the conclusions? So, there is a poster on this, poster 352, which I'll be by later and happy to go through some of the nitty-gritty here. But in our primary outcome of lung transplant or death, stratified by race and ethnicity, there was no difference. But when you kind of look into these numbers a bit closer, what you do find, it looks like the black population is at a particularly high risk of dying from CF and less likely to have been transplanted. So why? We did account for these things: CF-related diabetes, CFTR modulator eligibility, and insurance. Insurance status. We sort of adjusted for these things. So why are we still seeing this signal? So you have to ask yourself: is there a role for bias here? And again, this is really hard to sort of tease out in a model like this, but this is certainly something that comes to mind. And with regard to the secondary endpoint, Asians with CF tend to have a slower FEV1 decline than the black population with CF. What were the limitations? So again, there's imperfect designations of race and ethnicity. If you have a child who's the immigrant of Nigerian parents, for example, and they have CF, they're going to be put into the black, non-Hispanic group just as much as somebody who's multi-generational American. And those are two very different people that are in the same category. So it's an imperfect designation. We use this, I credit the foundation for having these GLI equations available to kind of adjust for race and ethnicity, but it's not a perfect adjustment, but it's the best we've got. We know that there's an underdiagnosis of CF in minorities, which may skew a model like this. Now, these models were not specifically adjusted for Medicaid, which is something I think I'm going to do. Instead of looking at public health insurance, because somebody on Medicare is not the same as somebody on Medicaid, and we know that Medicaid is a risk factor for worse outcomes. And then, of course, I didn't mention this, but this data set does not really adequately capture all of the population of modulators, right? We're only through 2019, where we may have gotten, maybe a substantial portion on prescribed therapy, but whether they had it on hand is not clear based on the timeline we chose. I want to thank the CF Foundation for the PACE Award, which gives me some protected time to work on stuff like this, as well as the data. And Kristen Staggert is my biostatistician extraordinaire, truly a wizard with this stuff. And Dr. Jane, I know she's in the back. Thank you so much for your mentorship. She's met with me, maybe ad nauseum for her, but I don't know how she has time for people like me, but she does. Very much appreciated. Couldn't have done this without you. And I leave you with a wise quote from Bill Nye, that everyone you meet knows something you don't. And I hope I was able to show you something new today, and I hope to learn from you all as well. And these are my references. I'll take any questions.
Thank you, Dr. Devarajan. Any questions from the audience? Okay, perfect. We'll start with another one here then. How many patients had CRMS and CFTR-related dysfunction in this group, and why did you elect to put these patients in your study?
Oh, that's a good question. So, yeah, I don't, this is something that I could get for you. I don't have the breakdown by who had CF, who had CRMS, and who had CFTR-related disorder. I think actually that is kind of important. We should probably look at that just so that there's no major differences between the groups. But the reason we decided to do it was, number one, they are in the registry. And if you went to the CFTR-related disorder talk, was that yesterday afternoon? What you take away is that there's a lot of uncertainty, right, about what label to put on people. Sometimes, they have all the symptoms of sinus disease, and they have bronchiectasis, poor weight gain, with even though they're pancreatic sufficient, and then their sweat's kind of somewhere in between. You pick up one CFTR variant, but the second is unknown or missing, and so we thought. Because we had their data and because they are often seen in CF clinics as well and are subject to sort of the same type of treatments. Some of them are even modulators, right? That we thought it would be best to include it to sort of make it a little bit more generalizable to a CF clinic. Dr. McCauley.
Great talk. Thank you for doing this. I hope everybody knows the last real paper on this was in 1998. I'm not going to ask for that was overdone yesterday, but I just wanted your thoughts on the GLI reference, because GLI has very little, a very low population from Africa, but we also know in the United States, if you look at true ancestry using genetic markers, there's great variability, and that using ancestral markers can help you look at lung function more accurately. This was published by Raj Kumar and Esteban Burchard and others in 2011. But particularly looking at the distribution of CFTR variants, there's a lot of F508 del, even though it's much less than other populations. And so are we underestimating lung function severity and leading to death or ability to be listed or transplanted in the Black USCF population?
Yeah, that's an amazing question.
Yeah,
so what Dr. McCauley had said for those that came here is that we use the Global Lung Initiative adjustments for race and ethnicity, which actually is based on a really small Black population. And so what may be more important to look at in further studies is actual ancestral origin, like if you were to do, I don't know, what we could use, maybe 23andMe or one of these types of commercially available ones, to actually figure out where people sort of, their ancestry comes from. Maybe we could sort of put them into appropriate, better categories in terms of looking at their lung function. Is it possible that the Black population's lung function is actually underestimated or perhaps overestimated because of the sort of imperfect equations that we use? Yeah, I would say that's definitely true. I would be interested. I have to say that I don't know a lot about this. But in looking at GLI, it seemed like compared to a lot of the other sort of normative values that we use, Hankinson and Haynes, this is an improvement. It's more inclusive. It includes more minority populations, but as you guys may know from the pulse oximetry data lately, that there's, using the commercial pulse oximeters across racial populations, it looks like we underestimate, or rather we overestimate what the pulse oximetry shows in the Black population. And obviously this was not intentional, but it is a reality, and this sort of this could potentially lead to a lot of disparities in care, especially during COVID, for example.
If I can ask that, I think that there's, well, ancestral origin is interesting and certainly largely impossible in a it also would negate the massive impact of social construction determinants of health and structural racism when we're thinking about race as a social construct, particularly in our country. And I think there's a lot of argument towards using race neutral or non-corrected factors when you consider how much does assume that Black people have lower lung function than baseline, and that assumption actually does go back to slavery and justification of enslavement.
Yeah, so the comment was that if you were to go back and you were to make more ancestral determinations of which sort of bucket somebody's lung function should be compared against, is that you may sort of negate a lot of the work and sort of adjustment for social determinants of health, because you might move populations from one group to another just using ancestry data, when the reality is this person, because they are Black, they might be subject to specific disparity that really has no bearing on where they may have originated from. I hope I summarized that.
Perfect. And one last question. In considering the role of bias, are there studies and other examples of known health outcome disparities, such as coronary artery disease, evaluating the role of bias that you could replicate to evaluate bias within the CF minority population?
So there's definitely a lot of other disease states, chronic diseases, where these disparities exist. So coronary artery disease is one. A lot of the newer papers on COVID-19 demonstrate for something that's acute that there are some health disparities that put the Black population in a worse position. The last question was, how can we apply that to replicate it? What they did. That's a good question. I think a lot of these disparities studies, and I don't consider myself yet a health disparities researcher. I'm more a dilettante at the moment. And what I'd say is that I think there are better ways to make sort of these adjustments. So I mentioned the Medicaid bit. I think that actually could skew this model a bit. The other thing that we were thinking, and actually Dr. Jane's paper on the Hispanic population did this, they actually adjusted by zip code because that information is available through the foundation. And what we might be able to do is kind of better characterize disparities by geographic distribution, because, right, I mean, I'm in this data set, you're looking at people in Maine, you're looking at people in Dr. McGarry's California, you're looking at Texas, so is this really generalizable to the whole CF population? I think adjusting for geography in hindsight makes a lot of sense, and I think that's something we'll pursue ourselves.
Awesome. All right, perfect. If you guys have any further questions, I'm sure Dr. Gray, he'll be around.
Yeah, I'll be around.
Thank you. All right, moving on, our next speaker is Melissa Alau. Melissa has been with the adult and ped social worker at Boston Children's Hospital since 2020. Melissa received her bachelor's and master's in social work from Salem State University, completed a postgraduate fellowship in the Department of Psychiatry, and she has over 15 years of social work experience working that has prepared her well for her role as a CF social worker. She will speak about implementing a social determinants of health screener in a large pediatric CF center. Please welcome Melissa.
Thank you all so much for being here. Thank you to Pridgie and Ryan for inviting me here. I'm very happy to be presenting the social work profession as a clinician. Thank you all for being here, and shout out to those in the hub and the overflow room. So I would be remiss if I did not acknowledge my colleagues who helped make this work happen. Maura Harrison, who's here in the front row, is my social work colleague. We worked hand in hand in this, and Rachel Gordon, who's not able to be here with us today, is our QI consultant, who made Maura's work and my work actually look very professional. So you'll see all kinds of lovely charts that we can look at today. So I'm going to be talking about implementing a SDOH screener in a large pediatric center. So I have no disclosures. So here's some background that you're probably all familiar with, but socioeconomic stressors have been linked to poor health outcomes in people with CF as well as others. People with CF are particularly vulnerable to food insecurity and due to cost of care, of treatment, inadequate insurance, coverage for supplements, and increased caloric fat needs. And food insecurity in the CF community is interrelated with other financial needs like housing, transportation, utilities, medications, and medical bills. So we decided in order to address this within our own center, we were going to develop a screener and intervene as much as we could with people with CF and their families in our clinic. So let's give some background about what the pediatric CF center looks like at Boston Children's. We currently have 250 patients. Our average monthly routine clinic visits are about 70 per month. And we currently have 1.5 FTEs for social work. 23 of our patients actually transitioned to the adult program during our first year of implementation, and additionally, we have 27 patients diagnosed with CRMS. Our objectives were to try to reduce inequities within our population by screening and addressing these needs. So in our first year, our specific aims were to screen 80% of our pediatric CF population and to follow up with 100% of those respondents who endorsed a need. Talk a little bit about the methodology. This is a new experience for me. I was only here for 2 months and I said, we should talk about social determinants. I had no idea what I was in for and how long it was going to take. So January 2021, I said, listen, the last program I was at was a post-discharge follow-up program where as a social worker, I would be asking every patient who was discharged, who was at risk for readmission, all of their social determinants of health. I realized very quickly in CF that social work sometimes has 10 or 15 minutes in the room. So how do we assess all of their needs? The best way to do that, I thought, was let's do a screener. Like I said, I didn't know what I was in for. So we did an extensive lit review. We found lots of screeners that were already in existence and more. And I said, you know what? I don't think these actually fit our population. We need to create our own. Again, I didn't know what I was in for. So we drafted a screener, an algorithm process. We were able to create a list of resources in each domain that we were going to cover because we said, well, what happens when the first person says, yes, I need help with transportation? And we go, oh, that's great. Let me go do some research. So that was really important for us to make those lists of resources for us internally. We then presented our screener to our QI team, to the multidisciplinary team, to our patient and family partners, and we made suggested changes before we started rolling out our pilot. We also recognized we needed to keep track of this data, so we created a HIPAA-compliant Smartsheet online database, and we finalized our algorithm. So we started our pilot in May 2021 with our goal of screening 15 patients. We were able to do that within about 3 weeks, which was really great. We broke them up into different age categories so that it was younger children, kind of children that were like 12 to 18 and then 18 and over, because we do have some young adults that are in our pediatric program. We continued with the pilot between June and August after we got feedback from those patients and families who filled out the screeners as well as from providers. And then we were able to present to the Health Equity, Quality, and Research Committee at Boston Children's Hospital to get some feedback as well. And then we implemented universal screening, and my slides did not format the way I wanted them to. So I just fixed them in the ready room. Whoever's listening in the ready room, it's not working. So we finalized our screener. We finalized a process for screening, so Maura and I print these out on beautiful blue paper. They're handed to patients at check-in as part of their packet so that they are able to fill those out in between PFTs and providers and vitals. And so when we go into the room, we can look at this really quickly and say, okay, these are the things we need to do, and this is how quickly we might need to be able to do that. So we incorporated it into our weekly multidisciplinary team review so that we know who is due for this, because we're doing this on an annual basis now. And also, if you screen positive, we're going to rescreen you in 6 months to determine if the interventions that we provided were helpful, are there additional needs you have, vice versa. And then we're continuing to review the data and ended up doing a health equity analysis. So this is a screener that we developed. There was an additional screener for young adults. We basically just changed it from your child to you. So it's the same exact screener, and it's available in English and in Spanish. So the 5 domains that we decided we were going to ask about for our families and patients was transportation, utilities, financial stress, as we know is a huge one related to medical costs in the CF community, food insecurity, as well as housing. So what Maura and I did is we chose particular questions from other screeners that we felt fit our population, and we also came up with our own. So the second question, asking about financial stress due to transportation, didn't exist elsewhere, but we were hearing a lot from families like, I can't afford gas because I live 2 hours away from the center, or it's really like $10 at the validated parking lot is also like a stretch. So this has been super helpful and wonderful. And if you can see at the bottom, we're telling people, tell us when you need follow-up. So we get a sense from the family, like, how urgent is this? Do you need us to follow up with you within 24 hours, or can we do that within the week? If you check not applicable, I'm still going to follow up with you because up top it says the social worker will follow up with you if you have any concerns. I feel like those people are kind of like, yes, I did have some financial stress, but I'm not in dire straits. I don't think I need anything. But we have found people that we've been able to actually provide assistance to because they didn't realize they were eligible or they don't want to take it from someone else. So I feel like that happens all of the time. And I said, if you weren't eligible, I wouldn't be offering this to you. So it's okay. You can take some support. So when we look at our monthly screening rates during our pilots, it was 25% of eligible patients. So anyone that was coming into clinic, we were able to catch at least 25% of them, which is great. And over time, our screening average has increased to 54%, which I think is great. We'd love to increase that. And I think when we think about, why are we not catching 100% of people? Well, we're not robots. We may not be in clinic that day because we felt it was really important that social work needed to be there in case there was something that comes up. I don't expect a doctor, a nutritionist, a physical therapist to be like, oh, I'd love to talk with you about how we can get you here to your next appointment more quickly. Just like I wouldn't expect to be going into a room and being like, let me talk to you about your PFTs. We're also going to look at, so these are the positive screens by domain. You can see the top 3 most frequently reported areas of concern were utility bills, financial stress due to medical needs, and transportation costs. And when we break this down over time, what we found is that when we break down how many questions did people answer. So 46% of people that filled out this questionnaire had one item on one domain. 18% had 2 or more questions. 13% had 3. 6% had 4 questions. 6% had 5 questions. And 10% checked off 6 of the 8 questions. This was actually a shock to me. I knew that social determinants was going to be positive, like this is going to be great, we're going to document it all. But to think that 10% of people had checked off 6 different items, I think is something that we need to be thinking about. Okay, so now we're going to break it down by race. I will say that this system is flawed, and though I will say that because our medical record is where we're pulling the data. As you can see, 38 of our patients are listed as unknown. And that's because there was nothing in their medical record. I also want to acknowledge that when race and ethnicity is put into the medical record, I have no idea who put that information in. Did they ask the family? Did they make an assumption? Did they ask a parent and now a child is a teenager or an adult and they're like, actually, I identify as multiracial, not black or white or whatnot. So this is something that we're working on both the adult and the pediatric side, is how do we get some more accurate data? But not to like hide the lead, but in the Hispanic population, so the people who are self-reported in our medical record, 29% had positive screens. And you can see this is higher than the white population as well as the other populations that we have in our clinic. Look at positive screens by insurance. I'm going to shock you all and tell you that people with public insurance also had higher rates of positive screens. When we think about private insurance, that's their primary insurance. In Massachusetts, we're lucky enough that many of our patients can apply for secondary Medicaid if they have a disabling condition, and Medicaid Mass Health decides that they're eligible for that. So there may be some mixed in. So we just took private as their primary insurance. So let's talk about some of the screening limitations that we had, because there are many, as there always are. So we had limited staffing during the first year of development and implementation. I started, like I said, 2 months before we started this process. I'm half-time in the pediatric program and half-time in the adult program. Maura's full-time with me on peds, and I had a part-time adult social worker who then left, and then I had to cover the entire adult program where there was about over 360 patients, plus whatever I was covering with Maura. So it made it a little difficult. Like I said, I did not know what I was getting into when I started. Sometimes the screeners were misplaced, so the family filled it out, but Maura and I didn't get to the room in time to grab it, and then we were like, where's the blue paper? And we're going to the front desk, and we're going to the nurses, and sometimes they got misplaced. And so you hate to have someone fill it out again, but I also hate the idea that someone filled that out and they may have had a need and we couldn't address it. So what kind of message also is that sending to families? So that made me pretty upset. We did have staff turnover, both at the front desk as well as nursing, kind of everywhere. And then our screener is only available in English and Spanish, but we do have families who speak other languages, their primary language. It's a little hard to do that through an interpreter. I feel like it doesn't always translate very well, but we do what we can. So some rescreening limitations that we found, because talking about every 6 months, if you are screened positive, we are going to continue to screen you. So there may be patients who are overdue for follow-up. They don't actually make it in on a regular basis. They may be missing their scheduled appointments. So I was supposed to meet with them on Tuesday, but they canceled or they no-showed or they didn't have transportation. Sometimes we're still following up with them within 6 months, but we didn't have them fill out an official screener. We just said, hey, the last time we met, we talked about SNAP benefits. Were you able to get your food stamps? And then pre-visit planning. So it's great that we can talk during a multidisciplinary team meeting, but if someone gets scheduled the day of or the day before, we haven't planned for that, and it's not always on our radar because we're managing a lot of things in clinic. So, summary and conclusions. We were able to pilot and pretty rapidly expand our routine screener in our pediatric center for people with CF as well as caregivers. And our QI-driven process revealed potential health disparities amongst Hispanic respondents with public insurance, and those coming to clinic less than recommended. What are our next steps? There are many, and I'm just going to highlight a few that we've talked about that we want to address right away. We definitely want to increase our rates of screening. So our goal was to do 80% of our population. We got to about 70, which I think is still pretty good within a first year, but I would like it to be higher. Rescreening families with positive screens more regularly, because I feel like when I've got 10 minutes, I'm just going to go in and see how it's going, but I feel like we really need to be better at officially rescreening. We need to address these identified disparities, because I knew they were there, but now that we have the numbers, which I've learned being a clinician, if you have no numbers, no one really cares what you have to say. Oh, that's so sad. How do you do your job? But now I have numbers to show you, like, we need to put efforts into this. We're hoping to work with our DEI team at Children's and other patient advocates, both within CF and within the Hispanic community that are part of patient advisory boards, like, what's the best way to address this equitable across the system? And then how are we going to screen people that are not coming to their visits? Because right now we're doing it in person. Our medical record, unfortunately, is not the greatest. We will be switching to another one in a couple of years or 18 months or so. So it's really hard to send this out electronically in a way that's meaningful and not overwhelming, where we have to send it to all 250 patients at once. That would be impossible. And then we're going to also hopefully address the screening limitations. So again, I'd like to acknowledge my team, particularly Maura and Rachel, our nurse coordinator, Kate Barnico, our medical director on the pediatric side, Greg Sawicki, the BCH Department of Pediatrics Quality team, as well as the Health Equity Quality and Research Committee. Thank you so much for your time.
Thank you, Melissa. Question for you. What was the average time frame people wanted to follow up?
I would say, most people would say 1 week. I'd say that's a vast majority. There were a few that said, like, I need food because I'm not getting food stamps for 7 more days, and we don't really have enough food at home. But so those things definitely happened.
And then Melissa, another question. While social determinants of health issues do tend to be long-term, they can emerge acutely in certain situations.
Yes.
With screening occurring every 6 months in clinic, how do you help patients and families deal with these acute needs when they arise?
Yes. So I think one great thing about implementing a screener is that even if a family says on January 1st, I have no concerns in any of these areas, and I say, great, my job is done, have a nice day. I say to every one of those families, thank you so much for filling this out. I want you to know if any of these things come up before next year when I'm screening you, I want you to know we have resources here that are able to help you. So if you have an urgent need in clinic, like we have grocery cards, we used funding to buy gas cards because we realized that a parking voucher is not enough because parking is only $10, it's validated, but your gas may cost you like $25, $50 depending on where you're coming from and what kind of car you have. I have a patient who has a big diesel truck, and she was like, I really wished I knew that this was going to happen when I purchased this truck 5 years ago. And so in the moment, we can provide concrete resources. We also utilize federal programs, state programs, local community programs, programs within our hospital, as well as private and local CF foundations. We have a wonderful foundation that we work with. I'm going to call them out, Megan's Light. who provides wellness grants. They work with a couple of hospitals in Boston, and we have recognized that food insecurity is through the roof, to the point that I was a bit surprised about how frequent it was. And so they're able to provide grocery cards on a quarterly basis to our families. It's not going to feed their entire family for 3 months, but it does help them, where now they can take that money and maybe they can put it towards their overdue utility bill, or they're behind on their rent or their mortgage. So those are just some examples of things that we've been able to provide, and I hope that answered your question.
Yes.
Yeah, I have a question, and it's really based on the carceral nature of the Child Protection Service and the fact that many families from minoritized backgrounds are hesitant to disclose.
Yes.
And we've heard this from patients' families and from community members engaged in the National Organization of African Americans. So how do we normalize this across communities, screen everyone, just like we are hopefully doing depression and anxiety screening, and make sure that there is empathy and help behind it, so that we don't miss people who have this double influence of poverty and racism at their field.
Melissa, can you summarize the question for
That's
those
a
in the
great
hub?
question. So my brain just went, poof. I heard your question. I was formulating my answer. But yes, please. I know how to answer your question, but you did it so eloquently. I wanted you to repeat it.
So what I was asking about is the carceral nature of the Child Protective Services in the United States, and the fact that that makes people from many minoritized groups not disclose because they think your action may be to take custody of their child if they disclose they don't have enough food, or if they don't have transportation to get to clinic.
Thank you for that question and for repeating it for everyone. So that's, Maura and I had quite a few discussions about that, because we didn't want people to be worried about, like, well, if I tell Maura and Melissa that I don't have enough food, are they going to call DCF on me? That's what we call it in Massachusetts. So what we tried to do in the language, that's why I pulled back up the screener, is to normalize that we ask this of every family. This is voluntary as well, but also, you know, some people find that their income doesn't meet their needs. So what we're trying to do is normalize that across the board. I think the lovely thing about cystic fibrosis is we have ongoing relationships with these families. Hopefully we're seeing them quarterly, at least twice a year, once a year. And when you have an ongoing relationship, the hope is that maybe you don't feel comfortable the first or second time you get this, but now that you know me, you know that I understand you and what's going on in your family, maybe next time you'll be more open to actually discussing it with me so that we can address those issues. There have been people, you know, that tell me things and they're like, I'm afraid to tell you this. And I was like, tell me why you're afraid to tell me something. Like, how do I get the answer out of you without getting the answer out of you? And lots of times people will express that. So I'll say, okay, so if you're concerned about DCF, these are the types of things that I would be concerned about. And I would go through all the things that I'm a mandated reporter for. Same thing happens when they talk about suicidality. When they're talking about mental health, they're like, I don't know what I should tell you because I don't, and so I explain what that process looks like. So even if they leave that day still not feeling comfortable, they can sit with, okay, this is what Melissa told me is going to happen if something like this happens again. So I hope that answers your question.
Melissa, there are many great questions in the chat, but one that I think is really important. Will there be an effort to validate these screeners and then make them available for use in other CF centers across the country?
That is a wonderful question, and I'm going to let both of my directors know that that is happening. My adult director happens to be in the back of the room, and I plan to expand this to our adult program ASAP.
Thank you, Melissa. All right, and our final speaker for this session today will be Kristen Clem. Kristen is a social worker with more than 10 years experience in program development. She joined the CF Foundation in 2017, and at the CF Foundation, Kristen and her team work to break down access barriers for people with CF. Since 2018, she has co-led the CF Food Security Committee, which has created materials to support CF care teams, increased awareness about food insecurity among CF clinician community, and participated in several research efforts. And she'll speak today about the benefits of medically tailored interventions for people with cystic fibrosis.
Thank you. All right. Thank you everyone for being here, and thank you to Bridgie and Ryan for the invitation to speak. I'm really honored, especially to speak after all of these incredible presentations. So my name is Kristen Clem, and I'm going to be presenting on the benefits of medically tailored meal interventions for people with cystic fibrosis. I do not have any relationships to disclose related to this presentation. So to start off, what are medically tailored meals? Medically tailored meals are meals that are delivered to an individual living with a severe illness. Most of the medically tailored meal programs start with the HIV community. Meals are typically, individuals are usually referred to these programs by a medical provider due to the need to vouch for their illness. And they're not just any meals that they receive. The food items are selected and the recipes are tailored specifically to meet the dietary needs of people living with that illness. So many, probably most actually, of the food programs that exist would fall at the bottom of this pyramid. They provide food to people who are food insecure to meet a basic need and to prevent future illness. What we're talking about today would fall at the top of this pyramid. Medically tailored meals that are provided to people who already have an illness, and the food is used as a form of treatment. The food is medicine. There are several programs, many programs across the country, and several research studies have been done to understand the benefits of these programs. I should say none of these were done specifically on people with CF, but you can imagine looking at this list that these benefits would also be really greatly beneficial for the CF community. There are just two that I want to talk about. First is our second bullet point of lowered healthcare costs. So a 2018 study found that people receiving medically tailored meals cost the healthcare system 16% less than those who are not receiving medically tailored meals. One interesting thing that I learned during this process was that 6 months of medically tailored meals is the same cost as a one-night stay in the hospital, which I was shocked to hear that number. The other one that I wanted to point out was fewer days where mental health has interfered with quality of life. We learned from a recent study that people with cystic fibrosis who are food insecure are more likely to have an abnormal mental health screen than someone who is not food insecure, or someone who is food secure. So the organization that I'm going to talk about today that we worked with is called Food and Friends. They are a community-based organization in the DC area, and they provide free, completely free, medically tailored meals and groceries to people with severe illness. Before we started working with them, they did not work with the CF community. We started our work in January of 2021, went through a 3-phase process, starting with program development, which I'll talk more about on the next slide. The second phase was a 6-month pilot of providing medically tailored meals. And then the third phase was an evaluation, during which we performed one-on-one interviews with clients, as well as did a clinician focus group. But for today's presentation, we'll focus on the results of those one-on-one interviews. So during the program development phase, a lot of learning took place. We learned about what the Food and Friends program, the services they offered, how it worked. But they also learned a ton about the CF community. We connected the local CF dietitians and social workers to Food and Friends, and together we created a menu that was specifically tailored to meet the dietary requirements of people with CF. We worked on updating their application process. And then finally, the Food and Friends trained care center staff on how the referral process would work and how the program would work for their patients. Creating the menu was really probably one of the most exciting parts of this process. It was really fun, but there were a lot of challenges. All of the existing Food and Friends menus at the time were exactly the opposite of what is needed for the legacy CF diet. The food was lean, low in sodium, low in calories, and low in fat. So that was a barrier to overcome. Additionally, we know the trifecta, the dietary needs of people with CF are changing a ton, and everyone really needs an individualized approach. So what the Food and Friends staff ended up doing was taking their higher calorie menu items from their heart healthy diet and adding in fat and salt. So they did things like adding butter to the vegetables, adding extra cream to the mashed potatoes, doubling a portion of peanut butter, or doubling a portion of trail mix. So once the menu was created, the care center staff were trained, the application process was set in place, we started a 6-month pilot. During that time, 16 individuals with CF received medically tailored meals, as well as 6 of their family members. This came to a total of 5,678 meals during that 6-month period. We did have a limited number of people who would be eligible for the program during the pilot, so we did some prioritization. We came up with 3 groups for priority referral, and so of the 16, 3 of the individuals were living with or had recently had an acute exacerbation, 3 were living with advanced lung disease, and 10 were considered pediatric patients. To evaluate the program, like I mentioned, we did one-on-one interviews. We either interviewed the adult with CF or the parent of the child with CF. And one of the things we wanted to find out was if this program actually alleviated food insecurity. So we asked about their food access before the pilot and then during the pilot. And they had to choose between never a challenge, sometimes a challenge, or always a challenge. You'll see up here in blue was before the pilot started, and in gray was during the pilot. So there were 9 individuals of the total 16 CF families who we interviewed. So before the pilot, 7 of the 9 families said that food access was sometimes a challenge. During the pilot, 8 of the 9 said that food access was never a challenge. The one caveat here, that one individual who was still having food access challenges during the pilot, unfortunately, they had limited storage space. They had to reduce their number of meals. Then we wanted to know or understand why food access was a challenge before the pilot. Almost all of them said it was due to the high cost of healthy foods, which I think all of us understand. Food prices are changing rapidly. Many of them had unreliable transportation. Many of them lacked energy to grocery shop or prepare the meals. Some other things that we heard about were people were, due to COVID, they were afraid to go grocery shopping, or there weren't healthy food options near where they lived. Then to better understand the benefits, we asked them to choose between the options on the screen. 100% of them said that this intervention saved them time, saved them money, and increased their access to food. 78% of them, or 7 of the 9, also said that this intervention lowered their stress, improved their diet quality, and allowed them to focus more on their CF care and treatment. Now, the pilot was only a 6-month period, so we couldn't have expected many actual health changes. But we did have some conversations with them as well. 2 of them said they gained weight. 2 parents of children said they lost weight. 2 identified increased strength, and 2 identified increased energy. I wanted to share these quotes from some of the clients that we heard during the interviews, just to show the impact of the program. So from an adult with CF, they said, "It has allowed us to not have to decide what's for dinner, and alleviates decisions that need to be made about food shopping, recipes, and actually making the meals." A parent of a child with CF said, "My daughter has gained weight and I'm losing weight because I'm eating healthier. I'm so happy." Additionally, I have this quote up here from Food and Friends, and they found an additional benefit, not just for the CF community, but for a couple other of their groups as well. This new high-calorie menu that they had, they were able to also serve it to individuals with weight loss due to HIV wasting syndrome and individuals with weight loss due to their chemotherapy treatments. So we were thrilled that 16 people with CF were helped during this pilot, but since the pilot has ended, they have formally included people with CF in their list of eligibility guidelines. As of last week, they've served 31 individuals with CF and 18 of their family members, coming to almost 15,000 meals. They also served 13 birthday cakes, which I thought was a fun little addition. We've continued to collect data and hope to, in the future, better understand the impact of this program, especially on health outcomes. And we're exploring additional partnerships because we hope this only serves people in DC and surrounding Maryland and Virginia counties, so we hope to be able to bring the service to other areas as well. In fact, just Wednesday, I met with MANA here in Philadelphia, and we'll be starting a pilot next year. So that's already an exciting win for us. I'd like to acknowledge a ton of people who work together in this. My colleagues Kim Reno and Karen Carey at the Foundation, Carrie Stoltzfus and Leslie Woolley at Food and Friends, Carol Chase at Children's National, Elizabeth Davies and Shannon Spada at Inova Fairfax, and Marcia Davis at Johns Hopkins. These are my references, and I'm happy to take any questions.
Thank you, Kristen. We'll start. Did all the centers who participated already have a food insecurity screener in place?
That's a great question. All of them were screening for food insecurity. Interestingly, being food insecure is not necessarily a requirement for these programs because it is based on their medical need as opposed to their need for food. But yes, many of them were screening for food insecurity.
And then we have a great question here in the chat. Were patients offered choices for meals and groceries?
Yes.
And were cultural preferences taken into consideration with the foods that were offered?
Great question. Yes, they were able to choose meals or groceries. It did depend on their geographic area. So for those of you who are familiar with the DC area, anybody within the Beltway could either choose from meals or groceries. Anybody outside the Beltway could only choose from groceries due to the time it would take to ship the prepared meals to them. The second part of the question, cultural considerations, yes, they absolutely consider that. So although Food and Friends offers this high-calorie menu option, there are alterations available, and the individual also doesn't need to choose the high-calorie meal option if it's not what best meets their needs.
Perfect. Is there a time limit for patients to participate in this program?
Nope, since the requirement is just having cystic fibrosis, as long as you have CF, you're eligible. They do reevaluate on a yearly basis, so if someone doesn't really need it after a year, or really at any point, they can stop the service.
Someone asked the question, do you know how Food and Friends is funded?
A couple ways. Their main funding comes from fundraising. There is some payer work that they do, so some reimbursement from payers, but most of it is based on fundraising.
And then someone says, this is a fantastic project, and it's great that you're expanding to other cities. In DC, are you planning to collect more quantitative data now that you've established more long-term collaboration?
Yep, absolutely. That's our next goal because we really do want to learn more about how this impacts health outcomes. Food and Friends does also collect quite a bit of data, so since they didn't previously serve people with CF, they weren't collecting the data on the CF community, but we hope to learn from them and also continue working with the care teams who referred the patients and collect more data.
Thank you, Kristen. I think that's it.
Okay, thank you.
I'd like to thank all of our speakers for speaking today, and thank you to everyone for coming. If you do have additional questions for our speakers, we'll ask that they stay down front and be available to answer questions. Thank you again.
Thank you.